Good morning, everyone. Good morning. We'd like to welcome you to our City Council study session, meeting for Thursday, March the 10th. All of our council is present because we have Councilmember Spilsbury with us via Zoom from, I assume you're still in New York, Julie?
Still in New York.
Okay. Well, thanks for making
Good morning.
to be part of this meeting. The first item on our agenda is a presentation to provide direction on the proposed use of American Rescue Act funds for the city's public safety response model for mental health and related 911 calls. This is, I know, a topic that we're all very interested in and was a subject of the State of the City a couple of weeks ago, so it's good to assemble the cast of that presentation. But if there's nothing else, please take it away. We're anxious to hear more about this.
Okay. Good morning, Mayor and Council. My name is Amanda Freeman, and I'm from the Office of Management and Budget. And with me today are Matthew Moody and Andrew Irwin, and we're going to present on the 911 mental health response. You may recall that we presented to you in June of last year, and we promised you that we would come back and give you some updates on how that program was doing. And so we're not only going to give you those updates, but we're also going to introduce phase 2 of the program. So I'll turn it over to Matthew and Andrew.
Great. Mayor and council members, thank you for having us here this morning. I first just wanted to acknowledge the team that you have here in Mesa. We've been working with law enforcement agencies across the state, and Matthew in particular has been going out and setting up programs like the one that we've done here. And the team that you have here got this program implemented in half the time of anyone else. So we were able to implement our diversion.
Or maybe just move on. Oh, yeah. There we go. Yeah, we'll try that.
How's that?
Speaking of-
Better?
Oh, yeah, there you go.
All right. Sorry about that. But as I was saying, your team implemented the program here in 3 months. So no one else has even come close to that. And I think it's just really a credit to the professionalism of the folks that you have working here. So my name is Andrew Irwin. I'm the Chief Operating Officer at Solari Crisis and Human Services. We're going to talk, as Amanda said, about the diversion program that we've implemented with your team, and then phase 2. I just wanted to start off by giving background on Solari. So we are the largest nonprofit behavioral health crisis line in the United States. So we serve Central Arizona and Northern Arizona. So obviously 2/3 of the state, 3/4 of the population. In a given month, we take between 24,000 and 28,000 crisis calls. When I say crisis calls, what that means are calls about coordination of care, anxiety, depression, domestic violence, all the way through to people that are actively suicidal. In addition to the crisis line work that we do, we also send out 2-person mobile teams. So those are people that will actually go out in the community and meet with members face-to-face to try and stabilize them, and if necessary, bring them to an inpatient facility. So we dispatch between 3,000 and 3,500 teams to go out into the community every single month. Just in the past year, we dispatched 4,800 mobile teams to Mesa alone. In addition to the work that we do on our crisis line, we also work in the space of social determinants of health. That concept is that there's certain issues that influence people's health care and behavioral health. So poverty, access to shelter, food, and things like that. So we acquired 211 of Arizona in 2016. That's the Health and Human Services line that serves the entire state. Last year, we took 11,000 calls from Mesa residents and assisted them with housing, utility assistance, food insecurity, and issues like that. The concept behind that is that if we could try and upstream issues, we would actually prevent people from having to engage with our crisis line. So now I'm going to talk a little bit about the structure of the crisis system in Arizona. I just want to give that background in case people aren't familiar with it. So Access is the main funder of the crisis system in Arizona. They are a Medicaid, Medicare administrator. They delegate out the work to be overseen by what we call the Regional Behavioral Health Authority. Here in Central Arizona, that's overseen by Mercy Care, and in Northern Arizona, that's Arizona Complete Health. So those systems, they oversee the 3-part process that we have, which is represented in those 3 boxes in the diagram there. We have a crisis line, we have mobile teams, and then we have inpatient facilities. That 3-part structure is considered a best practice nationally. There's only 2 states that have implemented that full structure so far, and that's Arizona and Georgia. Georgia sends everyone that wants to get the concept to us to do the touring, which I think is a concept on what we've actually built here. So the way that that functions is that the crisis line is the main input. People call us for that support. If we can't stabilize them over the phone, then we'll send out a mobile team to support them in the community. If the mobile team isn't able to support them, then they're able to bring them to an inpatient facility. So you sort of have a tier of progression there from top to bottom in terms of giving those people assistance. Nationally, as I mentioned before, people come and visit us because they see it as a best practice. Over the past few years, we've had New York, California, Wisconsin, Utah, Oklahoma, a whole host of states come out and actually work with us to try and implement those programs in their own states. This past month, we had a team from Calgary, their law enforcement agency, came out and toured our facility. We had Alaska last week, and then we're having Oakland this week. I think the weather helps a little bit in terms of people's willingness. So the Alaska and Calgary folks, I think, were trying to escape the winter. But I say that just to sort of give you all a sense of where our crisis system is in terms of our sort of development and the way that we engage with law enforcement and the community. It's not to sort of brag, it's not a perfect system, but in terms of the investment, this is where people come to get ideas about how to do work differently.
Mayor and council members, good morning. My name is Matthew Moody. I'm the Director of Contact Center Operations at Solari Crisis and Human Services. As you all know, the Morrison Institute did an amazing poll here in town of Mesa residents, and they found that majority of residents do not want law enforcement involved in nonviolent mental health calls. And that's kind of the foundation of this whole project. Mesa's been amazing in leadership, like John, Chris, and Amanda here have been awesome at coming forward and saying, who are the experts here? How do we do this? What's the best way to do this? And they really came to us and asked us how to do that. So when we talk about these other communities that are coming from across the country and internationally to see how things are done, Mesa is really the cutting edge of this. And so when I talk to people about how to do this type of work, I'm really holding up the work that we've done here on how to do this, even down to the policies and procedures that other police departments are using. So if you go to the next one. So the whole idea that we started with is how do we divert 911 calls away from the 911 system and the city services and first responders at all when we can handle them with this crisis line and crisis system that's been built up over the years. And again, we're seen as experts across the country. So when we started the program, we wanted to see what types of calls we could send over and change policy to do that. And if you go to the next slide. Mesa was actually the first city that I'm aware of that ever changed their policy in the way to send people who are feeling suicidal and aren't in immediate danger over to a crisis line that specializes in this type of work. A lot of cities across the country are building their own systems. So they're putting their own crisis specialists in 911 centers. They are creating their own mobile teams. Mesa saw the way forward, in my opinion, what is going to be the model for the rest of the country, which is let's have this separate entity that specializes in this and serves the whole community and move them over to that entity. So you can see in late 2018, and so again, way before anyone else in this realm was even doing any type of work like this, we changed the policy in 2018, I believe November, and you can see in 2019, we started to see the numbers go up to 369. Last year, after starting co-location, which we'll talk about in a second, which started in June 2021. Sorry, excuse me, I was trying to get my names together. We actually hit 1,867 calls. So you can see we're making a big improvement. And over the last 2 months, we've seen that number continue to rise. So we're predicting 3,600 will be the total for 2022. So when we came to council last time, we had a goal of increasing calls 100% after co-location began. And again, co-location is a Solari staff member sitting in the 911 center, coaching and consulting with the 911 call takers, training them on the crisis system, how to use it, and what types of calls are effective to send over to the crisis line. So since we started the program and changing the policies again, we're up 175%. So everyone at communications and the police department are really excited about that number. We also did additional policy changes. Again, what Mesa Police and Mesa Communications did in 2018 was very cutting edge then. The changes that they made in November last year are really forward thinking as well. We've also trained 100% of dispatch staff, and we've been co-located since June of last year. Were there any questions about the current process, about the co-location, about the diversion process so far?
I'm sure we all have questions, frankly, but I guess the question is, do we
wait till the end?
do we interrupt, or do we, I've been writing down questions.
Okay.
So
I'll wait till the end.
maybe we'll just let you proceed and come back.
Great, no problem. So I just wanted to clarify, that's already what's happening. So everything we discussed is already happening, and we're going to take a step into phase 2.
Yes, so this process flow represents phase 2. Essentially what we're proposing is that you all integrate into that crisis system that we talked about earlier. So the concept being is that we're going to leverage our crisis contact center. We're going to utilize mobile teams, and we're going to use those inpatient facilities. But what we want to do is have staff dedicated to Mesa, meaning that we'll have staff members that are dedicated to taking calls from 911 dispatch, and then we'll have dedicated mobile teams just for Mesa. That means that you're going to get the benefit of the system that's already built, the infrastructure, the technology, the data that we already have and we deliver to 2/3 of the state. But you're going to have specialized teams that work within the community and are working on the issues that are specific to Mesa residents. There's a lot of law enforcement agencies right now that are sort of searching for what is the right way to go about this. And what we've seen is that there's a lot of folks that are sort of trying to reinvent the wheel. They're trying to come up with systems on their own within the facilities that they have, meaning the police department, the fire department, independent of the crisis system that's already been doing this for 2 decades. We think that this proposal is a good medium in terms of saying, let's leverage what people understand, let's use this proven, nationally developed process, and then create something that's customized for Mesa residents. So as you can see in the diagram, we're going to have our contact center. We're going to have a dedicated dispatcher that's going to work directly with the Mesa 911 team. We're going to have the dedicated mobile teams, and then we're going to leverage that mobile team during their downtime to go out and do the community work that the community residents need in terms of addressing homelessness, and then follow-up calls for people with behavioral health issues that are calling into 911.
Maybe we could just describe what happens today without the dedicated team. I mean, you have teams that are available to respond today, but it's that proximity and response time. And I think that's what's key to this
Absolutely.
proposal today.
So currently we have 30 mobile teams that operate in the Phoenix metro area. We have response times for the general public of 1 hour and half an hour for law enforcement. So those are the 2 standards that we judge ourselves by. What we're suggesting is that we're going to have teams that are within a Mesa catchment area, and we're going to see those response times go down. When we get calls from law enforcement right now, they're really sort of juggling out, what do I do next in terms to resolve this issue and then get back into the field? And they have options. They can go to an inpatient facility, they can bring somebody to jail, they can bring somebody to an emergency room. Those are sort of the issues that they're dealing with. And the time that it takes for a mobile team to respond to them is something that could keep that person into the community, and is going to be a lower cost intervention that's going to be more directed to the type of services that they actually need. So in terms of a structure, what we're going to see is that we're going to have a specific response for law enforcement that's going to bring that 30-minute response time down, because we're going to have that team co-located here and ready to go out in short notice.
And that's just so important, because as we've been talking about this, my focus has really been on that patrol officer, right? And providing that patrol officer all the resources they need, either from the beginning to divert the call so they don't have to get the call, or if the call comes that now this is important for us, because otherwise you may have someone waiting, a patrol officer tied up for 30 minutes just waiting for the response. And we get it, because it's, they're spread throughout. So the idea is now to have dedicated teams in Mesa. And that's the program we're trying to promote here, or support with the funding, so.
So as we've been talking about, there already are mobile teams in the community. When John and Christine came to me and asked, how do we improve things for Mesa residents? The idea was, how do we reduce response times, right? Like, how do we get things out here as fast as possible? And so that's where, excuse me, this idea came from, is let's create more teams through the same system with the same oversight and training and experience that we already have, place them in Mesa so they'll only respond to Mesa police, and then specialize them to the needs of Mesa. So when we went to law enforcement, we asked what are the big needs, and obviously, people experiencing substance use issues and people experiencing homelessness. These are big issues that Mesa residents are concerned about and could use help, right? So instead of those mobile teams just being available to take calls, which they will be from the police, we're going to set them up with an EMT. So they'll have an EMT in the unit, which is something that hasn't happened anywhere else in the crisis system. And they will also focus on substance use, homelessness, and follow-up. So when they're not actively on a dispatch, they'll be out in the community. They can go check on people that might be consistently having issues. If the police call and say, hey, we've got this person, we don't necessarily need 911 response, but can you go check on them real quick? Even though they aren't, calling in and requesting help through 911, that is something that these teams can help with. So the response times will go down having these teams here. Both the providers that will be staffing and managing these mobile teams, La Frontera, Impact, and CBI, are well-known partners in the community. Community Bridges has a facility here in town. Impact has been in the Valley for 30 to 40 years, I believe, and run 20 of those 30 mobile teams that are working in the community right now. And one thing I think there's a huge opportunity here is because Mesa is working on the cutting edge here, we can tailor these teams to city needs, right? So as time goes by and we continue to use these teams, we can tailor them to the city of Mesa's needs, and that's something that the mobile teams in other cities aren't able to get that specialized service. But also we can develop the best way to do these things, right? So we can use the experience from these teams working in conjunction with law enforcement, communications, and see how could these teams be even better? Do we need to make changes with them? Do we need to change their policies and procedures? Can we change 911 policies and procedures and police policies and procedures to better meet the needs of the community? So that's kind of a description of the mobile teams. As we've seen, co-location has been really successful with that 175% increase since last year. We think that having more co-location, right now we're doing 20 hours, we'd like to do 40 hours. Having someone there that knows the crisis system really well has a lot of benefits, especially in the moment collaboration, when someone can look over and say, hey, can you take this call? Is this something you can help? Or just having someone in the room. When I'm in the room doing this type of work, I'll hear people say certain words like suicide, crisis, psychosis, something like that. And then I can perk up and say, hey, hey, what's going on that call? Or I can listen in live and say, that's something that we can take. So having someone in the room is very powerful, but also building that relationship and trust with, between the crisis staff and the 911 staff is really powerful. 911's been around since 1968, and they're very effective, and they're very well trained, and they're nervous to try new things because they care so much about the people that are on the phones. They want to make sure that everybody's safe. So helping them build trust in these new systems is important, and so seeing co-location has been powerful for that. And so this is just kind of an overview of all the benefits that you're going to see. Mesa is the first in the nation to adopt something like this. It's cutting edge. Like I said, they came to the experts, and we worked with all the different organizations in town to kind of come up with these ideas. It's efficient, so we're leveraging the system as we have, which is best practice, and finding these ways to make it a quicker response time and to meet more people. And then we're specializing it for the city. So I think this is this is an exciting opportunity. I haven't seen anything like this in 14 years in mental health. When I work with these other cities in town and when I work with these other cities across the country, they're not as forward thinking and willing to jump in and to push the boundaries to meet the needs of their community. So for me personally, it's very exciting, and thank you to everyone that's helping make this happen.
So, excuse me, the cost you see here is an annual cost. It is staff recommendation that we enter into a 2-year contract. We have allocated enough ARPA funds to cover the 2 years, which is going to be an estimated $2.5 million. The top line are the staff, administration, technical support, and equipment that would be needed in the dispatch center, so in our dispatch and in their dispatch. And then the bottom line are the 2 teams themselves. So there will be 2 teams. Each team is available 70 hours per week. Do you have any questions?
Yes, I'm sure we have a lot of questions.
I'm going to leave this slide up because I'm
Okay.
guessing there's a question about
Great.
that.
Mr. Luna.
Thank you for the presentation. This is really exciting. I mean, we've been wanting this for a long time, and thank you, John Pombier, for leading this initiative. We're very excited. Tell me about the individuals that are actually responding in terms of their qualifications, their degrees, and experience. Can you describe them? Who are these individuals?
Yeah, they're counselors, they're social workers. Generally, those 2-person teams that are going out into the community, they have at least 4 years' experience and a bachelor's degree. There's different combinations that we use. At times, we'll use the master's level clinician along with a peer, so that's somebody with lived experience. And then the intervention looks kind of like a counseling session, and then it's helping them come up with a plan for next steps. If necessary, it's bringing them to an inpatient facility.
So these are somewhat seasoned individuals that have experience, can deal with mental health issues, and can respond. So you said 4 years minimum, maybe of experience, and
Exactly.
bachelor's as well as master's degrees.
Correct. So these are people that have generally experience within outpatient setting. So as case managers, they understand how the system works, and then they're taking that next step to actually doing that work face to face in the community. We have, as we mentioned before, just 2,400 of these dispatches in a given month. So they are seasoned, and that happens very quickly. They all go through specialized training ahead of time as well, so it's not just their education. Those are month-long trainings where they're going along and shadowing with somebody that's done the work for a significant amount of time, and then they will partner up into a team.
I appreciate your working with Community Bridges and Impact, that they have a long record of working with our community members. Those individuals as well describe their education. Would you know that, or?
Yeah, the mobile team staff members are the same level of experience. And something I like to say is that crisis work is a very special type of work. It's not the same as being a licensed therapist, which I happen to be. When we go through counseling school and social work school, they don't typically teach you how to intervene one-on-one with someone who's having an emergency and a crisis. So the folks that are going out on these calls, like we said, we look for experience. We typically haven't found people that are coming straight out of school, have the expertise that you need. You need to get out on the street. You need to meet with people. You need to see people in these situations. And so when we talk about the specialized training we get, that is them going out and going through these situations. So I always like to say it's kind of like an EMT. That's the kind of help that you want when you're having a heart attack. You don't necessarily need a neurologist. They might be able to do the job, but they're not specialized in that.
Right. Now, I appreciate the notion that we have co-location, that you have the crisis facilitators, individuals at the 911 center. Are they only working 20 hours or 40 hours, or are they on call? How does that work?
So the co-located staff spend 20 hours a week in the 911 center, and then 20 hours a week as a crisis specialist, so doing the typical crisis role on the phones. And the goal of that is to maintain that they are fresh on how to do crisis work and are maintaining that understanding and are up to date on the types of ways that we're helping the community from the crisis side, and then kind of learning to translate that to 911 police culture and
Right.
talk, I guess.
And you also said that you have trained some of the dispatchers to look for keywords in terms of responding. Because if you're only doing 20 hours, then what happens when you're gone?
Right. One of the other benefits is, so yes, we're training them while they're there, and we did, I think, an hour training with everybody, and then we're constantly like reaching out to them and providing them examples of things that we can help with and certain situations that we can help with, and letting them know how we would have handled certain calls. But also, it's building a better relationship. The supervisors at the crisis line know a lot of the supervisors from Mesa Communications. And so when they have those interactions, they're like, oh, I know who that person is, and we can start to build a better level of trust. So even when that co-located staff isn't there, there's a better relationship being built over time.
I think that's something to be clear on too, is that that co-located staff is coaching and building rapport. They're not taking calls. So it's not that there's downtime, it's that we're teaching those 911 dispatchers what the policy says, how to get comfortable with the type of calls that are being transferred and identifying those calls. So the concept is more around coaching them and making that presence regular so that they're comfortable moving those calls over, as opposed to us trying to dedicate staff where we just wouldn't get as much coverage and as many calls transferred.
Now, I know you're only doing 20 hours a week. Is the goal to increase that? Because, I mean, we're 24 hours. I mean, 911 happens at all times throughout the day and the evening.
In phase 2, we plan to double that to 40 hours a week.
Okay, and you only have one individual there, or how many individuals are?
One at a time, there's 3 of us that have done the work and can do the work.
Okay, so great. Thank you. Thank you very much.
All right, I'll go next, but I'm sure there's plenty of questions. So I know you've answered this question, so I apologize because I'm asking you to repeat yourself. But can you just boil it down to me? And I know you're working statewide, which is great. So what does that model look like? What does the current model in Mesa look like that you're saying we're one of a national leader? So how does what's happening in Mesa look different than what you're doing in the rest of the state? And then the third part of that is, what is this Mesa 2.0 model? How is that going to be different than what it is now?
Sure.
And I know you, again, I apologize. You've answered this question, but I just somehow I need it, just dummy it down for me a little bit.
Sure.
Yeah.
So when we started, we had our crisis line, and we're asking people to call into it. If they need assistance, we send out mobile teams. What we started to do was to change the policies within 911 centers and ask them to transfer calls to us. And that's what that graph that Matthew was showing you earlier was the first transition. Not every city is doing that. What really separated Mesa from other cities was that you guys built it into a policy and let your 911 dispatchers know when you receive this type of call, this particular code, you should transfer that over to the behavioral health line. We don't want to send law enforcement. We don't want to send fire EMT. We want to have a behavioral health intervention. One of the big takeaways coming out of that was that 50% of those calls, we didn't have to do anything except talk to that person over the phone. We're able to do that counseling session over the phone, and we're not sending out that fire EMS, which would have been the response 90% of the time coming out of 911. So that's a big shift. So that was phase 1. And now what we're talking about in phase 2 is giving you all dedicated mobile teams that are just going to respond to Mesa. Currently, there's 30 teams. They're all across the valley. And you all are sharing that resource amongst all the other cities. There's different needs dependent on where you are. And what we're saying is that you can have a group of individuals that are constantly working within this catchment area that's going to reduce response times. But in addition to that, we can talk with them about what in particular does Mesa want to address. So if that's substance use and homelessness, which I know have been brought up before, we can have that team when they're not responding to law enforcement out in the community doing that type of work. Does that make more sense?
It did. Thank you very
So I think we missed just kind of the step in between.
Sure.
Right, because the first one you said, just having dispatch could call your folks, but now, today, you actually have someone coaching them.
Correct.
Right, so that's kind of the in-between step, right? Progressive, like you said, we've been working on, and so the state we're at today is, instead of just telling dispatch it by policy, you can call them, we actually have, coaches, as you refer to it, staff from Solar there to really be, there in the call center, helping understand and working with them and kind of real live examples of what's happening. But yet, we're still having to dispatch these teams from this larger area. So now we're trying to, if you see, we're kind of coming closer in and bringing those resources closer to Mesa is now what we're trying to accomplish.
So Mr. Brady led a discussion a week ago, Thursday, at our strategic planning meeting where we talked about response times, and we had I wish it had been broadcast because it was a very good presentation, and it touched on this, and it touched on the fact that sometimes that we're still, unfortunately, have this model where we get a 911 call and we send out a ladder truck, right? And it might not be that we're sending a screwdriver when we need a hammer, or we're just obviously not responding with the appropriate apparatus and personnel. And so it seems like when we get a 911 call now, we're either sending out a sworn officer or a fire truck, and the third option is a mental health professional. And it seems like right now, maybe we're sending out all three, and which is, to me, very inefficient. And so this is all boiling down to triage, right? When the 911 call comes in, well, the last thing we want is to put your people in a dangerous situation, right? So can you help me through, how do we figure out the triage, and how do we decide which number, how do we avoid sending all three of those?
Sure, certainly.
A cat in a tree, right?
Absolutely. And we have the data to support that. So we're able to see that we're taking about 1,300 calls total from 911s across the state. Less than 1% of those, we're actually calling out law enforcement to support our teams in the field. And in addition to that, we're not having adverse outcomes. So we're doing those 2,400 dispatches. We're doing this day in and day out, where we're sending those teams into the field. And we're not having circumstances where people are in dangerous situations. I think one of the things to sort of clarify is that the policy that we built is very honed in to the type of service that we deliver and the type of calls where we can support folks. So many of the times they're calling in and saying, I'm suicidal and this is why. And 911 was the number that I knew to call. And so historically, the response would have been to send out law enforcement or fire. Now we're transferring those calls over to our team, and we're talking with them over the phone. And 50% of the time, we're not having to send out a mobile team or anyone else. We can just make that person comfortable with their current situation, come up with a plan for them to be safe, and that's the next step. 50% of the time, we're sending out a mobile team. And so that's where our mobile team members are going out. When we're sending that mobile team, we're asking that person, do you want them to come? Do you want that level of support? We're not intervening in a situation where somebody's being combative and saying, I don't want you to show up here. These are people that are inviting us into their homes. They need support for their family member. And so the situation isn't quite, the way that we think about 911, where I've got somebody over here and I'm calling to get somebody else out there to deal with that particular situation. This is somebody that's recognizing that they're having a behavioral health emergency, they want some assistance, and they're asking for that team to come to their home or wherever they are to give them that help. And that's really the difference of, they're not in a position where they're going to be potentially harmed. Those aren't things that generally happen. I'm not aware of any incidents since I've been working in the contact center where that type of outcome has occurred.
Yeah, Mayor and Council, if you think about it, 911 has been the number that people call when they just don't know who else to call, right? It's not just for the critical emergency that we often think about, but it's, I'm having some kind of a crisis and I just don't know who else to get help. And so that becomes the default helpline. And so we get, obviously, you can imagine the whole spectrum of different kinds of levels of crisis. And so I think what we're trying to do here is to manage as many of those calls that we can take out of the true emergency and divert them into other, here on the PD side, the mental health calls that can really be handled by the specialists, the experts in the field that don't require, there's not a threat to life, there's not a, doesn't have a weapon or whatever. So there's a lot of those calls. And if we can just take those off, just think how much more time we've made available for the patrol officer. And then even on the medical calls, right, we talked about last week is lots of different medical calls that come in that doesn't really suggest, doesn't make sense that we're sending a big fire truck to. And so with 4 sworn officers, and so we're looking at different models to say, no, we don't have to always have to send that level. So we're trying to be very, because the number of calls across the board, whether it's police or fire, continue to grow. And so we're just trying to figure out how can we get better at really diagnosing what's in front of us and sending the appropriate level and types of resources to address those calls. And so this is one element of that, and we talked about last Thursday another way to address the lower acuity medical calls also.
Mr. Pombier, you have something to add to that?
And Mayor, you hit the nail on the head. This is all about triage at this point. Whether it's a response model for police, fire, or mental health, we have focused very heavily on the triage. That's why the co-location and that training and that mentoring is so important. Both police and fire management have been incredibly innovative in looking at these issues, but we went to the communication centers, and you've all been to the 911 communication centers. Our 911 call takers and our 911 dispatchers are amazingly busy. And we went to them and basically said, this program hinges on you and your ability to do this. And I will be honest, their response was amazing. They have jumped in wholeheartedly. They are trying to learn when to put the appropriate call in the appropriate basket. And their effort and their willingness to do it when they already had a full-time job that keeps them incredibly busy has been one of the most gratifying experiences during this process.
I love the terminology you're using of intervention. And it seems like sometimes we hear sad situations where families will say, we've been asking, looking for help for a few weeks and it didn't get it and it culminated in something horrible, right? So obviously we need to have a better model and this is clearly a step in the right direction to do that. So I'm very supportive. Ms. Spilsbury has her hands up. Julie.
Of course, one of my girls just turned the shower on. I'm sorry about the noise. I just had a few questions really quick. So I love this idea. I think it's so great. I'm totally in support of this. And when we talk about the coaching, is that something that we foresee always needing to happen? Or once the 911 operators are trained, they would then train the next people that get hired? Or is the coaching thing happen? Maybe I'll just ask one question at a time and mute myself.
It is something that we think should be ongoing. So when we actually began the program, we tried it in terms of sort of the trainer model that you just described, where they go out, they train like a manager to essentially tell people how to engage in the process. But what we've seen is that the staff want the interaction on the more acute calls. They want to have a conversation with a clinician about what's happening, and that's how they get more comfortable. In our contact center, that's the same model that we use. We make our licensed clinicians available out on the floor so that those folks taking the calls don't feel like they're out on an island by themselves. And that is something that can happen where it's acute, you know what, maybe it's just safer to send law enforcement and fire, and I'll just do that. And so we actually have the data set where we actually put Matthew in for a period of time and then pulled him back out, and what we saw is that the calls dropped back down. So based off of that, we do think we're recommending to continue to do that so that we keep that level up and that those staff feel supported in their decision-making going forward.
Okay. Oh, go ahead.
Just to add to that, when we look at the next steps, how do we expand this policy? What types of calls is the crisis system able to handle, and the city's management comfortable with changing their policy to send over to us? As those happen, we're gonna have to continually train the call takers at 911, like, okay, this is the policy, here's the new training, and then helping them understand why the crisis can handle that type of call. So you're gonna continually have that process as we go along and broadening the types of interactions that we can take over from the police.
Okay, great. And then is it fairly easy to be able to tell what type of calls, obviously they're at risk to themselves, but where other people are at risk? Do we have family members calling it, concerned about a family member's behavior, or are you guys able to navigate that pretty quickly as to when other people would be in harm's way?
Yeah, absolutely. So we work with families and friends and all sorts of third or second party referral sources. In those situations, what we're going to try to do is see if we can engage the individual directly. If we cannot, then we're going to talk to that third party and say, are you able to meet a mobile team there? Would you be willing to go engage this person with us and invite the team over? Or we provide them education on ways that they can help their loved one. So we can provide education and go over the steps they can take going forward. Also, it lets us kind of get a glimpse into what's going on, and then if there is a safety risk and safety issue, then we could engage law enforcement and first responders if it was what was needed to keep people safe.
Wonderful. I know that's a lot of times the issue is the family members that are concerned. My last question is just, I know we have some really great nonprofits and businesses in our community that deal with mental health issues. And so what is the coordination with the other groups in our community? Do we have referral systems, or where do you send people? Are you guys doing it all, or is there a referral system that we can use some of these other great resources we have?
Absolutely, and that's something that I should have mentioned in more detail in one of the big benefits to the system that we're having here. So every single time that a call is transferred to us, we're going to find out if that individual is enrolled with Medicaid and whether or not they have an outpatient treatment team that they're already working with. So we do that through a sophisticated process where we're actually looking at the Access database. We push their enrollment information into our electronic health record, and then we send notices out to all of the clinics that are working with individuals. So they actually get a notification that this person called us, and this is what their issue was, and this is the type of intervention that we gave them. Same thing if a mobile team goes out, they're going to be doing follow-ups. So just from a behavioral health component, we're getting a coordination of care that really the Medicaid system is built around. But on top of that, we do make referrals out to local agencies that are around them. So it is all of those items that I talked about through our 211 work, where it's going to be food insecurity, housing, all those other nonprofits that are in Mesa will be leveraged as resources for these folks. Generally, what we see is that there's a crisis that brought them to us in the first place, but there's those underlying social determinants of health that cause that. And that's really what we need to start to address to prevent them from coming back to the system over and over again.
Okay, great. Thank you so much. I'm in support of this. I think it's incredible, and I love all the innovative ways you guys are thinking to make this even better. So thank you.
Vice Mayor, did you have a question?
Yes, quite a few. So I guess I'll start with, I know within fire, we have a crisis response team, and I think we still have the CM units that would go out, or do we have those in fire? How is that coordinated or differentiated? We don't have CM units anymore?
We don't.
Okay.
Mayor, Vice Mayor Duff, we have Forrest here, and Forrest can come up and explain to you the difference. Right now, we don't have those teams in service. The contract that we had ran out with the company that was doing it, and they serviced a little bit in a different manner. We didn't take them out of the 911 PD calls. These were people that a lot of times their firefighters would go out and refer them to, and they would go out and help in those situations.
It may be a follow-up to an incident or something.
And so they were professionals that went out to follow up in a different context than the diversion of 911 calls. So right now, we're looking at options to reinstate that program so that can still provide all the benefits it did to fire and work in conjunction with this. We're just trying to figure out that aspect of it right now.
Yeah, I can see how some calls may need a PD response if the person is threatening suicide and they have a weapon. And I can see also that they're maybe having a crisis, of course, mental health crisis, but maybe they're an overdose situation or whatever, and we need that immediate health response. Is there a coordination that you're sending out people who are trained with mental health along with the emergency response so that PD, they try their best, but they are not trained to deal with mental health issues, and so someone has a weapon threatening suicide, we need a mental health professional to pull them out of that situation and make them all safe. I don't know, it's a very difficult situation, but there are crises where there's medical or public safety issues.
So the beauty of what we're doing right now, Vice Mayor Duff, is that our 911 call.
I was going to say, could you just sit here?
No, we got there.
Our 911, so when a call comes into 911, it goes to the same place. It goes to our 911 call takers. Right now, they have 3 baskets now: police, fire, and behavioral health. So there may be calls where they determine they need to have a fire response and a behavioral health response. This model allows them to do that. All right? So that still doesn't eliminate the need for what fire does. Their CM program provided a different level of care, especially a follow-up care. And so we're looking still at both, but this allows us to send the appropriate response. It could be all 3, or it could be any one of the 3. And I think I get really hung up on talking about the efficiency of the model and the innovation of this model. Let's not forget, folks, this is a better level of service for the individuals we're supposed to be serving. Absolutely. This is by far the most compassionate model that we've seen. The empathy that we're showing in this program by sending the right resource hopefully will change how we handle behavioral health, not only in the city of Mesa, but in the state of Arizona, because that is getting the appropriate resource to that individual to them in a way that they can accept it, which is going to be hopefully much more effective than in sending them one size fits all.
And this is a much higher level of service than we've ever been able to provide under any other program. So with the expertise and the fact that this run through Access, right? We have to forget, and I think that's the thing, and I appreciate the perspective. When we went into this, we still wanted to do something, we're not recreating the wheel, right? We're not trying to create a duplicate type of system. We had a relationship with Solari, but we were using them in a very kind of minimalist perspective. Now we're really bringing them in and working together. So we believe that, you know, from the city's perspective, we just do not have the expertise, the human infrastructure to understand all the training and all the skill sets, and we just don't have on staff the highly skilled, trained, educated supervision we would need. This, we think, will be help us. First, it's the 911 calls, right? And then we're going to figure out how to integrate. We've already had conversations. We're only giving you one phase. There's more phases we want to bring back later to address all the concerns. But when there is a weapon, when there is a threat of life and of harm, you know, the police officers are going to go. And our police officers are trained, but they're going to try to, you know, neutralize the situation. Our hope, though, is that we can keep those officers away from as many of these non-violent, threatening kinds of calls as possible. So.
Absolutely, I believe in this whole program, absolutely. I just wanted to understand if it's an either or, we're sending crisis response or we're sending PD, but we are layering and pairing those when needed.
Yeah, sure.
In those really urgent, sometimes maybe dangerous situations.
And Vice Mayor, the other area we expect to see an explosion of calls is the more our officers understand the resources that these gentlemen can provide, they may go to a call that we didn't realize was behavioral health related.
Mm-hmm. Yeah.
And when they get there, they may go, hey, dispatch, can you get Solari on them? Can you get these guys to send out a team because I need help? That's an untapped area, and we think that will be a huge resource to our officers as they learn the system. And they also build the trust with these teams and realize they're not going to sit there for 45 minutes or an hour. They might see them in 15 or 20 minutes, so that's a call they're willing to make. You know, we're really hoping that these teams become so busy, we got to look at ways to provide more, not less.
I will say too that what you're referring to is code dispatch as well. So there are times where somebody is having a circumstance where we need law enforcement to go in first, but law enforcement calls us and says, well, we want the mobile team ready to come in once we feel that the scene is secure. Other times we're getting calls from law enforcement saying, I've got an individual here, everything seems stable, but I can tell they need follow-up. Can you send a mobile team? So they actually leave the scene and they're comfortable leaving that person there knowing that that mobile team's gonna come out and support them. That puts the officer back into the field as opposed to having to deal with that situation on their own. So it really is the whole gamut of different ways to do that combination that you're describing.
Great. So I'm seeing that the mobile teams are when we can't talk to them on the phone for a variety of reasons, right? We need to be in person in the situation in order to, you know, take care of the person. So on the graph, we showed that in 2022, we had 3,600 calls. You said about 50% of them are mobile team responses. So that, if we say it's 100 calls a day at 3,600 annually, that'd be, and 50% were mobile, then we'd have about 50 responses for the teams to go out. Mm-hmm. Is 2 teams adequate? Do we have plans to increase that? Are you just, this is kind of getting our feet wet and seeing where we need to go? Are there any ideas?
Mayor, Vice Mayor, I think our ultimate goal is to begin with these 2 teams and see what response levels we get, see what utilization we get, and look for how we can do it better. As these gentlemen said, this is going to be a living, breathing thing. As we see what we need, we're going to change, expand, try to meet the needs of what we're seeing. I smile because I'm expecting that we have more demand as we build this program than we can handle, and we have to look for ways to expand it or ways to, you know, still work within the system. And these gentlemen will correct me if I'm wrong, but we're not out of the loop with those other 30 teams either. We're still in, by doing it this way, we're still in the system. So if as a city we had jumped in and said, we're gonna hire our own 2 teams, that would have been our only resource. Now we'll have 2 dedicated teams, and yet these other teams available when we have that need. So it's trying to figure out exactly how we fit within Mesa and then growing to meet that need as we develop the expertise.
So currently, we're not sending out teams.
Well,
we are.
we can call the team.
Correct.
Okay.
But the response time, when you talk to our police officers, for them, 30, 45 minutes, that's a long time to wait.
Okay.
So the idea here is to really have them much closer.
Absolutely. So right now, we've
Have
got those
dedicated
30
teams.
teams. It would be like having a fire department for the entire valley. And you've got that one resource and it's being pulled around. And what we're saying instead is that you're gonna have dedicated teams in Mesa. If those dedicated teams are busy, we will pull from the other 30 and bring them into Mesa to help support.
It's kind of like automatic aid.
And then we looked at the costs, but I assume there's an offset definitely to PD costs of maybe not taking these calls, being, so.
It's
although-
actually a force multiplier, right? Because now those officers aren't having to get hung up with those calls. They're available for other calls. So it improves our response time for everything else too.
And Mayor, Vice Mayor, it's an offset for the entire system.
Yeah.
Because now we're giving the appropriate service and maybe not taking them to the emergency room that's overloaded, maybe not taking them to jail. It is a force multiplier across the board for the community that we're trying to more effectively spend those resources.
Great. Well, once it gets all situated, I'm sure we'll all look forward to maybe a tour of seeing the co-locators in working in dispatcher maybe, from afar. And then looking back on this, I don't know, in 6 months or a year, whenever you're appropriate amount of time to kind of look at it and see how we're doing and how we can be better at it. And I think it's a great service for our city, and I appreciate that the city and Solari are working with us. Thank you.
Thank you.
Francisco.
Quick on coverage and response time. So is the coverage 24 hours? Are we identifying trends as far as when people are calling in more at night? Or, officers mentioned that a night service could be an issue as far as the people available to respond, right? So we're identifying those trends. Also on response times, having 2 dedicated services, are we hoping to lower the response times, I imagine, as far as the 30 to 45-minute waits? What's that anticipated for Mesa with these 2 new teams?
We're hoping to reduce it by 10 minutes. We're hoping that the co-location here is going to put us in a place to do that, and that is our goal as a group. Our analysis of when we're going to have those teams is built off of our workforce management right now. So we're able to see the number of calls that are coming in from 911 and when we're having to send out mobile teams. And so we're going to put those teams right during our high times. You're right to say that you have different sort of calls at different parts of the day. So we get more acute calls in the evenings and the weekends. And those are people that are just more acute in terms of needing support. There's less of them, though, and then we have high frequency times. We're going to be having these teams more in those more acute times, and we're just going to try and adjust that as we see the program progress. We do think that there is going to be more utilization, as John was mentioning, because the officers in the field are going to recognize this works, and I can have this as a resource. So we'll probably have to shift those teams as this gets used more and more.
Thank you. Mr. Freeman.
Thank you for the presentation. So a lot of my colleagues have answered my questions, or you have when they've asked, but when you first came here and gave your presentation, that was like 1.0? I mean, the first level, right? So now because you integrated your personnel into our dispatch centers and trained them, and so that's been very effective, obviously, by your graph. So that was what, 1.5 years ago or a year ago? How fast have we moved?
June of 2021.
June of 2021.
Pretty quick.
So this program is aligning currently in what we've done in the past, but also ramped it up. Ironically, I've advocated this program. Most of us sit in the National League of Cities and certain committees, and so when I've been in other meetings with some of my colleagues there, they're just totally just flabbergasted about how we're moving forward, and they want to have more information on this. But so we're all going to be back in DC this weekend, so that'll be part of my comments there. I really like the way that you've integrated into our 911 dispatch center. So when a call comes in, typically it goes to the police site, correct? And then on the police side, they decide whether it's medical or police.
Call intake goes.
So do you have your personnel on the police dispatch or the fire dispatch, or both,
The police dispatch.
on the police side?
Well, remember, police takes all calls, and then it goes to either fire dispatch or police dispatch. So every call comes into the, I'm calling call takers. Is that fine with everybody back here? Okay.
Well, dispatchers or?
Well,
Well,
because
there's
they're
call
all
takers and
dispatching.
dispatchers.
Well, there's different levels of dispatching.
Right, but you have a dispatch for police and a dispatch for fire. That's what I'm trying to make that distinction. But where it comes in that initial call, that's where they're helping to triage that.
I'm going to get in the weeds a little bit here. You talked about EMT. So you're having an EMT with your personnel. What level are you having as an EMT?
Oh, I think he was just using that as an example, right?
No, I think he said EMT, so
You have
that's a
EMT?
nationally certified position.
So for these new teams, yes, the
Oh,
plan is
the
to
new
have
teams.
EMTs
Oh,
in those
okay.
teams. Correct.
So what level of EMT? B, I, or P?
I do not know.
Okay.
We still have to have discussions on what the city wants with the providers and to make sure that they're meeting the needs of the city.
Okay. Because there's different level of training for each one of those positions, having been and done that. So P is the highest level, paramedic,
So
EMT,
the teams are
paramedic.
coming from your partners, right?
Correct.
From
We-
CBI or Impact.
But I guess, so you're just checking them on the medical side as a EMT, you're just making sure they're medically capable of being seen and not having to go to the ER and then going to the hospital of their choice or your choice for mental health evaluation?
Yeah, so as Chris mentioned, it is that those providers, CBI and Impact, will be providing the EMTs. They currently already have EMT programs, so that's personnel that's already part of the service they deliver. The main issue that we run into in the field is substance use, and it is those type of issues. Are they appropriate for this facility based off of their current situation, or do we need to bring them to emergency room? So we do get feedback from law enforcement pretty regularly that those type of substance use issues are items where they could use more assistance. So if somebody's saying that they want to go and get help, but they are intoxicated, is this somebody that's able to go into one of these facilities and get them to the next step? It's going to streamline that process and help the police officers get back into the field.
Yeah, and that's critical. When you talked about your work hours, how do you structure your work hours? I mean, for 40 hours a week, are you, what hours are you covering all 24 hours, or are you, say, tell me?
Yeah, so we've done an analysis, and I can't recall the hours off the top of my head, but we did that, as I was mentioning to Councilmember Hereda. It's based off the number of calls that are coming in from 911 already. So what we did is analysis of the calls that came in and where we had to dispatch, and then we're going to slot the teams in there. And so we're getting a total of 70 hours. I can't remember specifically the bandwidth.
It's 10, so the peak time has been identified as 10 to 10.
Okay.
And there was going to be a shift that started or a team that started at 10 and worked until 8, and then a team that started at noon and then worked until 10.
Okay.
And that'll be 7 days a week.
Okay. So thinking about Councilmember Heredia's comments about additional teams, obviously if our two dedicated team members are on calls, you would have to then get a team from your other 30, correct?
Correct.
To come in and hopefully facilitate that. Obviously, I think this is great. I think one of our objectives is to have the highest medical and mental health care for our Mesa residents, so I'm in full support, so thank you very much.
Great, thank you.
Thank you, Mr. Freeman. Other comments? I'm sorry, I have to throw in one other comment. This, to me, is one of the silver linings of COVID. I mean, remember pre-COVID when we were trying to figure out how to pay for everything? And Mary Camelli was pulling out her hair trying to figure out how to do cost recovery, you know, on all the social service calls that we were sending people out to. I think, thank God that we've got this ARPA money and we know how we're going to pay for this for the next 2 years. I'm already going to predict that this is not enough. And the times that I've gone on ride-alongs with the police department, it struck me that everything that we did on those calls was either tied to mental health or substance abuse. And so I don't know how we, I think this is going to be the default, that's the screwdriver, that we need in most of the situations that we deal with, it seems like, in the 911 calls. So it'll be interesting to see how this evolves. But I also think we need to, right now, start figuring out how we're going to do cost recovery 2 years from now so that we can not only continue this, but we can expand it. And when we go out to these calls, we need to have, maybe a finance person, as the third member of the team that figures out how to get everybody Medicaid eligible or Medicare eligible so that we can, not just drive away and we're done, that they continue to get the services that they need.
I think that's the beauty of their relationship with Access, Mayor, is that they can.
We will do
you're
the enrollment.
CFO, you can tell, they
Yeah.
know how to do that, and so they can, they're the experts and have that relationship with the state, so that really helps us. And you think about it, again, I'll just say it, for us to, if this continues to work for us beyond the time, the available funding from ARPA, if it proves up, what it's going to do is it's going to continue to take a load off of our public safety. And it's pretty easy for me to see that this is a much more efficient process, it's more effective. And at the end of the day, it's a lot less expensive than having police officers, sworn police officers doing the same work. So I think hopefully it grows and we can figure out the right balance of where this plays a role in public safety response, and we can allow our police officers to focus on the areas that they're skilled and trained at. So I think it will be a force multiplier, and I'm hoping that after we prove it up for 2 years, even if we don't have the federal funds, it'll still make sense from a city's funding perspective to continue to maintain it. So we're appreciative of the funding we have to allow us to kind of do pilot programs and experiment with these things right now. So it's good.
Thank you for doing this. Thank you for the great staff that we have that's been pursuing this and facilitating it as well. We're excited to get updates as this progresses and evolves. Okay.
Thank you.
Thank you very much. Next item on our agenda is item 1B. That's the appointment to the Economic Development Advisory Board. Is there thank you, Mr. Luna and Mr. Thompson, for that motion and second. All in favor, please say aye. Aye.
Aye.
Thank you, Ms. Pillsbury. That was unanimous. Next item on our agenda is acknowledge receipt of minutes of various boards and committees. Is there a motion to that effect? Thank you again, Mr. Luna and Mr. Thompson. All in favor, please say aye. Aye.
Aye.
Thank you, Ms. Pillsbury. That was unanimous as well. Next item on our agenda is current event summary, including meetings and conferences attended. I know a lot of us are on the cut next week. We'll talk about our trip to DC that many of us are going on later this week. But in the meantime, Mr. Luna, you want to kick us off?
Sure. Thank you, Mayor. Was it Tuesday? We attended the promotional ceremony for police. Is that Tuesday? So anyway, congratulations of those individuals that got promoted in the Mesa Police Department, and for Chief Koss for honoring their achievements. Yesterday, along with you, Mayor, and Councilmember Freeman, we attended a ceremony honoring the individual, the Good Samaritan recognition of the individual that rescued those 2 children from that fire, that horrendous fire. And so we had an opportunity to thank him for what he did. And it was great to meet him, and it was something that we certainly need to acknowledge and recognize. So that was a great ceremony we had. And then next week on Wednesday, Falcon Field will have a check-in meeting. That's at 6 p.m. So if you have any questions, it will be on Zoom, but I'll post it on my website and my Facebook, as well as Falcon Field website as well, if you're interested in attending. Thank you, Mayor.
Thank you, Mr. Luna. Council, other comments? Mr. Freeman.
I was going to say, there's a Mesa Police graduation this Friday, so we're looking for a new academy coming out. Thanks.
Thank you. Ms. Duff.
I was at the PD Awards program as well, and again, congratulate all those who received awards and promotions. I was also, the same day, I attended the East Valley Hispanic Chamber of Commerce International Women's Day celebration. It was a lot of fun, a great attendance, and we just celebrated the women before us and the women among us, making a better world. And So even though it's a couple days later, happy International Women's Day, which was on Tuesday, but we'll continue the celebration of our history throughout the month. Thank you.
Thank you. Council, anything else you'd like to share with us? If not, Mr. Brady, what does our future schedule of meetings look like?
We'll see you a week from today on the 17th for our next study session. Thank you.
Thank you very much. Is there a motion to adjourn? Thank you, Mr. Luna and Mr. Thompson. All in favor, please say aye. Aye. Thank you. We are adjourned.